Hello, everyone. Good afternoon. Thank you for being here for our Friday noon talk. Today we have an in-person talk. What a treat. It's my pleasure to introduce Dr. Piotr. He's a clinical medical physicist here at the McGill NPU. Many of you know him as one of the professors teaching radiation physics in the winter. And today he's going to be talking to us about research that he's done in advancing cardiac radiation. Thank you.
Yeah, Peter forced me to do the talk.
I invited you. I invited you in person.
I'm happy to be here. Yeah, so it's going to be about cardiac radioablation. I'm going to start though by introducing a little bit myself. It's been a while. First time actually I'm going to do this introduction here. So my name is Piotr. I was born in Poland. I immigrated when I was 3 years old with my family here. And since then I lived in Quebec. I spent 1 year of my life in France during a student exchange during my bachelor in engineering that I did at l'École Polytechnique de Montréal. Was it en génie physique? 2006, and then following that, I did the radiation physics program at the Montreal General Hospital, so the MPU, back in the day in 2008. Then worked a little bit, finished a PhD in 2016. I'm going to come back to all of this. And I've worked at various Montreal hospitals since 2008 as a clinical medical physicist. And since 2017, I'm here at the MUHC. And I'm also an assistant professor right now at the NPU. Okay, so that's the plan. So I'm going to start basically by an introduction. I'm going to go back to my master's and PhD thesis also. And then I'm going to talk about the cardiac radioablation portion at the end. So my master's in 2006, 2008. This was back in the day where at the Montreal General, we had Linacs without cone beams. And we had some cowboy doctors that wanted to treat SBRT patients, so liver SBRT more particularly, without basically having any imaging. So what we relied on was to have implanted fiducials near the tumor inside the liver, hopefully. We relied on as much patient immobilization as we could. So we had compression devices, we had kind of vacuum pumps that sucked out all the air from the patient so that there was no motion, intra-fraction motion. And on top of that, we did respiratory gating back in the day. My supervisors were Horatio and Dr. Robert from the CHUM right now, and also Dr. François de Blois, who's working at Electra right now. So the only type of imaging that we had to do these treatments was the portal imager and the MVB, right? So that's the only image that we had to during treatment. My project consisted basically on taking these portal images and finding a way to, well, first of all, identify where the implanted markers were with respect to the treatment field, and then comparing these implanted markers' position with the planned position of the markers from the DRRs from the treatment. That's the software that was written in Visual Basic back in the day. And the output was basically something like this, where you could see with respect to the planned position of the markers, what's the average position of the markers in all of the fields that were used. So back in the day, this was done with static fields at different angles, and each of these points represent a fraction for a patient's case, right? So with that, then we did different statistics, tried to figure out whether we treated at the right spot, yes or no. And this was pretty much all kind of post-processing after the patient was treated. It also involved creating a phantom, a kind of a motion platform that moved to kind of simulate respiration. And yeah. I'm talking about respiration because, like I said, this was gated treatment. So we were monitoring the patient's breath rates throughout the treatment, and we were only treating when the patient was in a safe.
Yeah, I will, Doug, yeah. Just because he started in different, yeah. Okay.
You in here? And so within this gated portion, the bottom, the red represented by the red dots, there was still some residual motion, right? So we're interested in knowing how much residual motion there was during the treatment, as well as what's the systematic shift that we kind of, or the setup errors that we had for these patients. So the tool was used a little bit in the clinic after I left, but mainly it was kind of, as soon as the CBCT technology was kind of implemented in the clinic, it was less and less used for this such a tool. So after my master's, and this is mainly due to the fact that I had the MSSS bursary that requires me to work 2 years after
the master's, after I finished my degree, I decided to work at the Maisonneuve-Rosemont Hospital. When I started, they just constructed 4 new bunkers, and they had 5 working LINACs and then 4 new bunkers with 4 new LINACs and with something like $1 million of new detectors that was bought also. So they needed a lot of physicists. We were 4 from my cohort to actually start working there at the same time. And we worked a lot on commissioning of these new detectors, commissioning of the bunkers and the linear accelerators themselves. And when you do all of that together, you kind of realize that it's actually very difficult to know if it's the chamber that is faulty, the cable, the electrometer, or the LINAC that is not set up properly. And it's kind of a circular pattern that you have to figure out which one is fault, right? Because it's everything at the same time. At the same time, also, it was maybe more in 2009, 2010, we introduced IMRT, the IMRT treatment planning technique at that hospital. So at McGill, IMRT started, or at the MGH, IMRT started probably in the year 2000. And Russell is not here, but he would say exactly when it started. Probably 2000, 2001, started treating patient IMRT here. But at Maisonneuve-Rosemont, the doctors were waiting a little bit more to see if it's useful, if we really need to go and do this new super complex technique. Plus, we had these new LINACs. So with the new LINACs, we decided to implement that a little bit later. I was part of this team also implementing that. It's quite interesting. And while I was working there for these 3 years, I took my time also and prepared for the board certification. Back in the day, residency was not required, but I had this kind of informal residency there because they knew that they had a lot of physicists that came straight from the program without experience. So they kind of gave us a residency at the hospital. And that basically allowed me to get my board certification at that point. But after working 3 years in the clinic, what happens, at least for me personally, is that I started to get a little bit maybe bored by the routine of the clinic and the environment where I was looking for a bit more challenges. The MCCPM was a very good challenge. There was lots of reading, lots of studying. But once that was done and coming back to just the routine work was a little bit less interesting. And that's where I decided to come back, leave my cozy job and come back to do a PhD. And he came back here to the, actually it was still at the MGH, but then we moved to the Glen. Did a PhD under Jan Sunjens and also under Dr. Issam El Nakwa. Some of you might remember him. He kind of did a pit stop here and then left back to the States. He did? All right, perfect, great. I missed it, sorry. And on top of that, I decided to do something that was completely not clinical. I wanted to do completely new stuff for me. So my project was called Numerical Models for Radiation-Induced DNA Damage. And I basically used kind of the newly published GN4 DNA model or code to do different simulations. And it was very, very new at the time, right? So nobody was working on microdosimetry. Shireen's lab was not implemented. I was pretty much the only one. Even my supervisor was just like, hey, let's look into this, right? So while looking at the papers, I realized rapidly that the first thing that happened is that the people started publishing quite a lot of results, going into publishing results of DNA strand breaks, double strand breaks, kind of biological results with these simulations. But they kind of ignored a little bit all of the parameters that are implemented in these simulations. In my first paper, I just showed that all of these parameters have a lot of impact down the line. So you cannot just publish the value of how much double strand break yield this energy gives without actually taking into account all of these parameter choices that you have in your code. That was kind of the first paper I did with collaboration with Mario Bernal, a physicist from, it was original from Cuba, but I'm not sure where he was then. No. And then my second paper, I worked with Fernanda and Gloria from Sweden. These were students from Dr. Anisio, Anders. And also that's where I kind of met Shireen when she came here to McGill. And on my second paper, what we did is we used a code that Gloria wrote to generate these tracks of particles. These were proton particles, and each of these dots represents just energy deposition that these protons would create along the track. So the tracks were generated with her code, but I used that in a MATLAB, let's say, script in order to superimpose these tracks on top of a cell nucleus model that I kind of showed before already. And the superposition basically was done simply using mathematical formulas and averaging and stuff like that, which allows us to do a very, very fast simulation of the relative biological effectiveness of different radiation. And here I define the RB as being a ratio of doses. It's the dose to deliver, or average dose to deliver a given number of double-strand breaks using, let's say, cobalt radiation as a reference, and we would compare that to different particle types. So with that, once again, we saw, well, one of the results we saw is that depending on the angle at which I irradiate my model, because my model was kind of a geometrical model with different shapes inside representing the DNA targets, depending simply on the angle that I chose, I had different values here for the double-strand break yields. So that was one result. The second result, basically, when I kind of took the average of that, I was able to pretty much reproduce the same data that other codes had. This was done with the Monte Carlo MCCPM code, and this was done with the part-track code. And my results are kind of in color here. So quite nice. These simulations were much faster also to generate. And my third kind of part of my PhD was trying to estimate now the RBE for kind of more clinical photon beams and the differences between different photon beams here. So I had cobalt, CBCP beams at different fields. I had even the spectrum that I think, Peter, you worked on, right? Peter, in your PhD. So I used your spectrum here as an input to my simulations and other sources here. And in this situation, what I did is, when you think about having a cell or so SV was for, what was it? Scoring volume, I guess, something like that. So if you had a very small scoring volume, that is irradiated by a clinical beam, a large clinical beam, well, the chances that a particle actually passes through your scoring volume are very minimal. You have a lot of particles, most of them will not pass through it. So doing this brute force simulation using step-by-step Géant-Tor simulation was just impossible. So what we did is kind of reverse the simulation. We said, let's just assume that there's one particle that's generated, right? That there's just one track. So where are the possible positions in space that I can put my scoring volume so that I actually score something, a dose, an energy position, right? And using averages, different type of averages and weighting, I was able to generate this really, really fast actually. So once again, this was using pre-generated tracks. So instead of generating all new tracks, I had a base of tracks that we used to do that. So that was my PhD. Yeah, let's just skip all that. And then once I kind of finished, after 5 years and lots of sweat, let's say at the end especially, I kind of realized that my whole idea of doing a PhD was to do a kind of like an academic career, I guess. And well, during the 5 years, things changed. So I got married, I had a kid, we had a house, and I didn't want to go and do a postdoc somewhere else. I didn't want to pursue the academic career. I had a very easy job opportunity as a clinical medical physicist. I just decided to go back. I worked and I see that, I think, I saw a name there. Some of my colleagues from the SHIM are present online. So I worked for a whole year at the SHIM on a maternity leave position. And I was calling William several times a month, I'd say, hey, do you have a position? Hey, do you have a position? Actually, he wasn't calling, it was email, he was not replying. At some point, he replied, and he said, well, we have a maternity leave position. So I switched at that point on another maternity leave here, which transformed into a permanent position quite rapidly, actually, and then I'm here since then. That's kind of my career path. And while I'm working as a clinical physicist, 100%, 40 hours a week, I'm also an assistant professor at the NPU, and that entails for me to have quite a large teaching portfolio, I would say. So I teach most of you, or I taught most of you also at some point. Right now, I'm some administrative tasks. I do participate in different grant writing propositions that we have ongoing at the NPU, and I also have, and that's quite new for me, maybe 2 or 3 years ago, only started to doing supervision of MSc and PhD projects. So if I kind of focus more on my research interest, I would say that my overarching research goals would be really to develop rapidly implementable clinical solutions in radiation therapy that have benefits for patients within a specific short amount of time. The main project I'm going to talk about is the cardiac radioablation here. I had another project with my PhD student, Nick, on devising new techniques to do LINAC QA that basically would improve the quality or the accuracy of our QA by a factor of 10, I would say, especially for SRS treatments, which is quite interesting.
And I also have a lot of collaboration, mainly with small animal irradiation projects. This is the case for mice irradiation on the LINAC. We also do different mice irradiation on the small animal irradiator that we have at the Research Institute. I also collaborate on different projects involving automation, workflow, and also auto contouring with different other collaborators. Okay, so let's go into the meat of today's talk about cardiac radioablation. So a year ago, I went to a specific conference on cardiac radioablation in St. Louis, and one of the slides during the presentation was this one. So what we should call this new thing, because it is still very, very new, and just the naming is unclear still what we should call it. It used to be called cardiac SBRT in the first papers, but now kind of the most US-based researcher and doctors will call it cardiac radioablation, whereas in Europe, it's still called stereotactic arrhythmia radiotherapy. So both of these acronyms are kind of still popular. It's the same thing, by the way, for SBRT. Some people call it SABR, right? I think SABR was the most preferred way, but I guess we call it SBRT just because we have always done it like that. Okay, so what that involves is the giving radiation to the heart. That's the main thing. And the heart is not an organ that typically has cancer. So it's one of these organs that is, we could say, cancer-free. There exists a situation where you have kind of sarcomas close to the cancer, to the heart, that you could call maybe heart cancers, but it's very, very rare. And for most of the radiation therapy that we do here, we avoid the heart as much as possible. It's always an avoidance region. On top of that, this is not a cancer, right? So we're not going to target cancer cells. We're not looking at destroying cancer. And that's not new for radiation therapy. So these are all different non-oncologic uses of radiation therapy. The three on the top here are in the brain. So different say diseases that you'd have that are cured with radiation delivered to the brain or to different substructures. But we also have different cases where you do it for different anatomy. But the main point of this slide, I'd say, is that most of the time, it's not true all the time, but most of the time, this is to relieve pain, right? So we use radiation to relieve pain in these situations, right? So it's not to treat cancer, stop progression, but it's to relieve pain. So looking at the heart is a muscle, various substructures in the heart. By the way, the population of cancer patients from head to toe is about the same as the population of cardiac patients, meaning patients that need something done with their heart, right? So it's in terms of population, cardiology and radiation oncology are pretty much seeing the same amount of patients. But cardiology is restricted to the heart. It's a muscle, like I said, the main chambers of interest, I would say, are for me at least, it's the atrium on the top here and the ventricles on the bottom. And yeah, so like I said a few times already, it's muscle. So this is really what it looks like inside. It's really just the la chair. And it's pretty much okay to irradiate it in the sense that there's no other structures around it. There's a little bit of valves around that you have to look for. So there's the mitral valve here and different kind of one of the cardiologists I was talking about this project too was saying to me that in cardiology there's two main kind of professions. There's the plumbers and then there's the electricians. Like, I mean, well, the plumbers were here to like unclog your arteries, right? So they just pass and they unclog, and the electricians, they're there to figure out why you have like a cardiac arrhythmia or something with the electric circuits, right? So there's really two kind of separate things here going on. So when you look at a normal sinus rhythm, what happens is that there's a kind of a signal, electric signal generated from this node that makes a contraction of the two atria, the two smaller kind of portions on the top. They contract, pumping blood. And then once the signal reaches this pathway here, this electric pathway, there's a little bit of a delay until the ventricles actually contract. And once the ventricle contracts, that's where the blood is pumped to your whole body, right? So that's what we see, the atrium contraction and then the ventricle contractions here. That's for a normal rhythm. However, patients that have a tachycardia, especially a ventricular tachycardia, what's going to happen is that they have a faster than normal heart rhythm.
And especially in the left ventricle, what's going to happen is if the patient had some sort of scarring, any type of cardiomyopathy could create that. So maybe, let's say, like I said, plumbing problems, let's say, in this region or around the region, creating some sort of scar in the left ventricle. These electric circuits, they're not able to propagate as well. And they're going to create these re-entry circuits that's going to kind of continuously make the ventricle pump. The heart rate of the patients are going to increase. And that's what we call ventricular tachycardia. So cardiologists, the electricians, they look at these graphs, I mean, all of them, right? These are ECGs, where you actually see these heart rhythms, the normal heart rhythm on the top, and on the bottom here, we see a sustained ventricular tachycardia for many, many, many cycles here, right? So, now, like with pretty much every disease, there's always different gradients of disease. So ventricular tachycardia at different stages is maybe easy to control and can be basically life-threatening. So what we do with radiation is we offer radiation to those patients that basically have no other way to get any pain relief, right? So if you look at the class here of different type of basically cardiac myopathies, we offer this radiation to classes 3 and 4 only. This is pretty much only done on compassionate care right now, or on a clinical trial. There's very little number of patients in the world that was treated up to now, and that's why we cannot just offer this as a standard of care, right? Although we're offering it to the patient that are the worst, but they have amazing results, like you'll show. Well, I'll see you like I'll show you in a second. So when we talk about these classes, if you look class 4 here, these are symptoms of heart failure at rest, meaning that any physical activity causes further discomfort. We had patients that basically are bedridden, they cannot do anything, right? And after the treatment, they were able to go back home, right? We have class 3, which is marked limitation of physical activity, comfortable at rest, but less than ordinary activity causes fatigue, palpitation, shortness of breath, or chest pain, right? So we had these type of patients as well with very good results. So when this ventricular tachycardia is kind of prolonged for maybe more than 30 seconds, I think the clinical definition is, we call this an electrical storm. And at that point, you can think of it like, think about being basically asleep in your bed, right? Bedridden. And you feel like you were just running a marathon, right? Your heart is just pumping 120, 130 times per minute. It's really painful. It can be painful. So you have different abnormal chest sensation, shortness of breath, and it can lead to passing out, cardiogenic shock, etc., when they're at this point. Okay, so I said different stages. So typically, if you have stage 1, you would probably just get different kind of a bag of different drugs, and I take drugs like 10 different drugs that you have to take to control your arrhythmias. And then if it doesn't work, or if you kind of progress in your disease, then doctors were going to try to attempt something called catheter ablation, where they come through your tights, basically here. They go with the catheter inside of your heart. You see fluoroscopy images here of what a catheter kind of looks live in the heart. And then the doctor with this catheter is able to kind of position the catheter where they want on the surface, on the muscle of the heart. And then with the tip of the catheter, they're able to exercise a temperature change. So they increase or they cook the heart, basically, right? They increase the temperature by cooking the heart, and they create a scar in this region. So the point of this catheter ablation is to scar the region that creates these re-entry circuits in the hopes that this electric circuit kind of goes around and it's just normal. You can go back to a normal heart, which is a weird way of, let's say, curing a patient, because basically you're creating more scars, so you're creating more problems down the line for this patient. But that's what the kind of the approach that they have right now in cardiology. I'm just going to show you a video. Watch out, there's going to be some sound.
Charge.
What it looks.
We're not going to get out of this. Everybody clear? Shut. Oh, this is
Another 96%.
from where? So
So you just witnessed the 5th resuscitation of this patient during this procedure. This was about the 2-hour procedure. In order to see an electrical storm or to do the catheter ablation, to know where to do it, they need to induce an electrical storm, which typically for these patients is going to put them in cardiac arrest. So the doctors need to resuscitate them with the, like you saw, right? So that's why this was flat, and now they have a heartbeat. A few minutes after this 5th attempt, the doctor said the procedure has to stop. He didn't have time to, let's say, burn all the spots that he wanted to, based on his initial plan, but the patient could just not tolerate it anymore. This is only anesthesia, but they look at the vitals of the patient, and they decided not to pursue it. I think if I remember correctly, this was the first patient that we treated actually in 2019. So it's a very invasive procedure, not super easy
Charge.
for the patient as well. And this is the results that like the doctors have with catheter ablation. So there's a good proportion of patients where catheter ablation works actually, right? So this is what you see on this graph on the top part is the amount of ventricular tachycardia events before ablation and after ablation. So we see for all of these patients, you basically have no VT events after ablation, and we're talking about 6 months after it. But at least from this graph here on about half of the patient, they're still going to have VT events. And there's a lot of patients actually that have more events after this, right? So we kind of actually increased the disease, you could say. So it kind of works, but not for everybody. So what's the problem with RF ablation? Well, when I was talking about cooking, you kind of see what happens here. So you're trying to cook, or you're trying to scar a part of this heart muscle with heat. Sometimes they do it, by the way, with cryogenic kind of catheters, but it's the same process. But you're not able to penetrate throughout the whole myocardium, right? With heat, there's fusion and everything, so you cannot stay there for an infinite amount of time also. So it like it's written here, it's nice, overcomes the transmural deficit of catheter ablation, and that's why radiation is interesting, because radiation we can treat everywhere, anywhere in the body without really thinking about the fact that it's deeper or less deep, right? Catheter ablation also can be very risky, and the complication rate of the procedure I was showing you is about 3 to 5%. And by complication rate, I mean patients dying on the table, right? During like not being able to be resurrected, right? So it's still very problematic. Now, depending on each hospital, they're not going to have the same percentages here, but it's a problem. And that's why also doctors might offer a second catheter ablation to a patient that has a recurrence. Maybe a third, but it's rare to go more than that, right? Because at some point it's just not possible to do it anymore. But that's why radiation is interesting, right? So we can do high doses of penetrating radiation, very precise dose deposition, and you can do it in one single fraction with very, very low acute risks also, because the patient comes in and out, and we're not going to kill the patient on the radiation oncology table here in our department, right? Unless he dies from a heart attack, I guess, but not due to radiation. At least not during the treatment. Okay, so worldwide, this all started just about 10 years ago. This was the first study. This was done on porcs, so porcine models, where they determined that the dose around 25 gray in one fraction creates fibrosis in the muscle, so creates scarring in the muscle, right? And this 25 gray in one fraction is the dose that's kind of kept on going throughout the world, throughout different clinical trials that happened here. The main 2 clinical trials come from St. Louis. We'll come back to this. And here, even in 2019, or name or city was here. This is us here from Canada. We treated our first patient in 2019. So when you look at the initial clinical trials that were published, this is the first one in 2017 and 2019 here. On the first one, there was only 5 patients that were treated. And you see clear that after treatment, all of the patients had no VT episodes. One patient died from a complication. Where exactly died? 4 months in. But pretty much everybody was VT free after radiation. And remember, these are, I think in this case, this was all of stage 4 patients, right? Those that were kind of bedridden, the worst patients that we have in the population. This was their second clinical trial, a phase 2 clinical trial with a bit more patients. Now they saw different recurrences, but for most of the patients, their recurrences level were far less than what they were previously. There was maybe one outlier here. So extremely positive results. Or first patient in 2019, like I said, even in 2019, this is such a new thing that the l'émission Découverte de Radio-Canada, so maybe CBC also has it. They came here and they did a little segment on us on the treatment of the first patient. This is the cardiologist and the radiation oncologist, Dr. Kijal, in this episode here. And since we started, I think we are now at 17 patients treated. Still, most of them are treated off or clinical trial at 25 gray. So like I said, this is a compassionate treatment offered to patients. And 7 are now on our clinical trial, which is a dose de-escalation trial where we're trying to lower the dose of 20 gray. We're the only ones in the world trying to do lower doses. Most people actually give higher doses, but even on these lower doses, and Ian is actually, Dr. Gerard is going to present the data that we have at ESTRO soon. We're still having very similar data that other clinical trials. So advantages of having lower doses allows us to treat larger volumes, one thing. So we have maybe less unprecision in how do we contour the actual target that we want to treat. Also allows us to spare more organs at risk. So sometimes you have the stomach or the l'œsophage close to the targets, right? So this allows us to spare them more, less complications. And we have the same results, or close to the same results, at least for now. That's why we're trying that out. Yeah. So if you look at the radioablation workflow, well, it starts with patient selection. This typically is a cardiology patient, so it's referred from cardiology. They need to find good candidates that now have to be kind of vetted, I guess, by the radiation oncologist, whether they are actually good candidates to receive radiation therapy. There might be some factors that would not prevent us from getting radiation. But once we know that, then we have to get all of the imaging possible and all the information, electric and cardiac information that we have in order to be able to target, right? To find where in the heart you want to target. And once we have a target, so a CTV, let's say, in the heart, then the rest of the process becomes really like an SBRT process where we just draw the target on the CT, set up our beams any way we want. Lots of centers around the world have different protocols for setting up the beams. Most centers treat on the LINAC. There's some centers that treat also on the CyberKnife. The advantage is that, advantage for CyberKnife is that all of these patients have different metallic implants, so leads here. Most of them have a pacemaker installed or a defibrillator. So you can use all of these metallic kind of leads or artifacts, let's say, to track using the CyberKnife. So that's also an option. And then we treat, basically, we deliver the treatment. The delivery itself is, like I said, 15 minutes. The patient walks out of the room with a smile and not like under anesthesia or anything like that. And yeah, and what happens and what our experience is that basically patients are getting better and better, even like a weekend sometimes or a week after, right? They're discharged from the hospital, they can go back to their activities. And some of them we have, I think for one of them, we have like a 2-year experience now that shows no VT. Sometimes they have a little bit of the VT recurrence, but most of the results we have are extremely positive. Okay, so this is kind of the general field of cardiac radiation radioablation. I'm more interested now in understanding the fundamental aspects of CRA. I have had a project and still going to continue having a project on finding ways to have better ways to delineate the targets, so more accurate target delineation, and also interested in looking at motion management during cardiac radioablation. So one key aspect that we still don't have an answer to is how does it work, right? So I said at the beginning, it's not cancer. In cancer, we are irradiating cells and we're killing cells. But what we actually do is we're generating a lot of DNA damage inside of these cells. And this DNA damage is not able to be repaired as well in a cancer cell than in a normal tissue cell. So cancer cells typically die, in normal tissue, sometimes they're able to live longer. So that's kind of how we kill the cells of cancer cell. Now we don't have cancer, we have just normal tissue. So is our goal really to kill the normal tissue and to make it disappear? Or what's the real goal? It was kind of difficult to understand why it's working. The initial hypothesis was that with a lot of radiation, we're creating something called fibrosis. So basically a kind of a scar, right? It happens in lung, it happens in skin, pretty much anywhere it can happen. And this is actually a CT report here that you see, porcine model. And that's from this paper that they saw that, yeah, 25 gray actually creates fibrosis in the heart, right? So let's try that on humans. They tried that and they had good clinical results on these few patients. The problem with fibrosis is that it typically takes months to install, right? It's not something that it happens over a weekend, right? Whereas we see results sometimes after a weekend, after a week, or a month, right? So now people are a bit more skeptic about the whole fibrosis or fully fibrosis hypothesis. And the other thing is that, well, fibrosis is actually kind of bad for the heart, meaning that this is a muscle that has to move. Fibrosis would restrict this motion of the heart. But for some patients, actually, we see that they have a better heart, right? They have more blood that is ejected after the fact, after the treatment, right? So we're helping the heart eject more blood using radiation. So now we're looking more into cardiac remodeling a little bit more. So what we think happens, or some researchers showed that by delivering a radiation, and that's now my understanding of what happens, is if you deliver radiation, yes, you create damage, but in a healthy tissue like heart, there's different mechanisms to repair this damage. And in heart specifically, these repair mechanisms, by basically being initiated by radiation, are going to start working, and the repair mechanisms are going to work in a way to remodel the circuits in the heart and maybe help the patient, right? Whereas without radiation, these repair mechanisms are not upregulated, right? So there's no reason for them to start working. Radiation kind of creates this reason, right? That's the working hypothesis that we have here. Another one would be kind of similar to that, but we would say that radiation creates kind of proteins that are arrhythmia protecting. So very limited evidence, still very little amount of basic radiobiology studies done on that. We worked hard to get some funding and some students involved at the RI and UHC. This is not directly my research, I'm just kind of tangentially involved with that at the Renzo Cesare lab. There's a student looking at that. And one of the projects that they're going to do is they have a way to isolate cardiac cells from patients, so from samples. And with these cardiac cells, they call them the pluripotent stem cells, they're able to create kind of spheroids, or I guess bunches of cells that are going to try to irradiate, compare what happens in patients that have these cardiomyopathies with normal donors. And we basically want to understand what happens to cardiac cells when they're irradiated with different dose levels. That's going to be his project here. Okay. My interest here was in accurate target delineation also. So I said already that we have this step of targeting here. And to target, well, you need to have a multidisciplinary team of people looking at all of the information and knowing where do we want to treat. And that involves cardiologists and radiation oncologists mainly, but also medical physicists here. It uses different tools for radiation oncology, so you're not used to look at necessarily all of this information here. So we need to have some sort of transfer information. And we are used to treat and to contour and to plan in our system, or treatment planning system. In our case, it's the CLIPS and ARIA environment, and not in other kind of contouring softwares. So during the catheter ablation procedures, the electrophysiologists are also able to take a map like this, a map of the heart. It's an electrical map of the heart. So with the same catheter or very similar catheter, they're able to touch at different places inside of the heart. So think about going inside of the ventricle and doing the imperial mapping of the ventricle. They're done at different places, and the color maps here represent a different voltage. So having a low voltage means that there's no conduction, meaning that the muscle it's a scar and the muscle is not going to contract, right? So in this patient who was very sick, you see that basically all of the red is where the heart is not, or the left ventricle is not contracting or minimally contracting, whereas this would be where the ventricle is still contracting. And the cardiologist, when they look at this and then they look at the this information and also sometimes at ultrasound, they're able to say, well, that's where I want to go, and that's where I would like to target a bit more, right? The problem is that this is only a screenshot. It was available in the Carto software. It's a completely different software that does not know DICOM. Very even difficult to export stuff from this software. So the traditional workflow that we had at the beginning was to actually look at this on two different screens, right? Like this, right? So you look at this image, now we try to figure out where this is on your CT scan, like this. Just like a bit difficult, especially that radiation oncologists and medical physicists were not used to seeing these images. We're not even sure what the geometry is. This is not in axial views. So quite demanding at the beginning, right? Yeah, I guess I said that already. Just another image. And this work, yes, this work was all done by Sarah, my master's students who finished last summer. And like she's saying here, there's no native way to import these maps inside of our treatment planning system. So yes, you can look at them side by side, but it would be better to import them. And that's what her project was about. So without going into how she did that, but she managed to create kind of a copy of this within our treatment planning system by creating a simile CT image that then we can are able to contour based on the electric values. Basically, now the levels of gray here would be the millivolts, same millivolts that you see on this map. So a very nice software that was developed within just a few months by her. This is how the raw data that she works with, and then she's able to generate that into a DICOM image. In here, I'm showing just a small study that we did. We have now extended that to more patients, but this is only on the four first patient that we planned before having access to this software. We tried to then kind of retrospectively superimpose the map on top of the patient and recontour, right, and see what different target volumes we would have. And what she saw is that out of the five patients, 4 out of the 5 patients required some contour modifications based on the fact that now we had access to these maps within our treatment planning system. One thing that you can see here is that this is not anatomical data. This is kind of a physiological electric data inside of the heart, acquired maybe 2 or 3 years before or 1 year before. So the time frame where this was acquired, it's uncertain. Also, the heart is moving, right? So it's not an exact perfect match, but overall, it's still a very good match to show the doctors where they want to treat. One thing of note also, the interior of the heart is full of blood. So we're not necessarily interested in treating the blood. We're interested in treating the myocardium, so the muscle around it. That's why even if the doctor sees all these colors here, they're going to still try to target just the meat part of it, right? So that was one approach. The second interesting thing is that now you have access to the map on top of a dose map, let's say. So with that, we tried to do different studies as to seeing, because we had some patients that had a map before radiation and after radiation also done. So we tried to look at the map after radiation and try to see if this was in any way correlated to what we did in order to see if there's fibrosis that was installed or something like that within the patient. So now this tool allows us to do that, right? To do these types of analysis. So with Sarah, we also worked on a review of the literature because our approach is not the only one available. And here she created this table where there's different approaches available. So one of them is the side-by-side approach that I showed you already, just looking at 2 different screens. There's a modified side-by-side approach that she classified a few of the approaches here. One of them was actually quite fun. It's basically a side-by-side approach, but instead of looking at a screen, you look in a virtual reality goggles, right? But then you have side-by-side here. That's paper. It's quite fun. I don't know. Although we call this modified, because there's kind of a side-by-side with little kind of gadgets around it. And there's different non-commercial software that are used also that were published, similar to what Sarah did. But most of these software are not within the treatment planning system. So they're completely different software that requires you to contour within the software itself and then try to export the contour from there. There's very few commercial softwares available right now, mainly from cardiology and extremely expensive software. And there's maybe one other paper than Sarah's paper on a solution that kind of allows you to draw inside of the treatment planning system. And this is just some results. Like I'm showing, like most of the papers previously published use the side-by-side approach. And one thing I just wanted to say about that is that we started to get a little bit of interest after her publication from other centers, kind of smaller centers that maybe don't have access to a student like we had here. And we just tell them, well, you can start using the side-by-side approach, and it's how we started, and it's still very good, and the results are still going to be good, right? So if you're like, you don't need to have this system to start. Most of them still are a bit scared, just like we were with IMRT, like I was telling at the beginning with Maisonneuve Rosemont. So most centers just going to wait until this becomes normal, and it's kind of reserved. CRA is kind of reserved for these academic centers. Okay. In this paper, we also have different recommendations, maybe not going to go too much into that, but we just wanted to have some sort of nomenclature, the same name in the papers. Like when people publish, wanted to keep the same names. You wanted to have the CTV volumes always published, as well as something called the associated segments, according to the American Heart Association 17-segment model. I'm going to come back to this model in a second here. This is Sarah's kind of overview of the project. So she had 3 major presentations, 2 internal presentations here. She published 1 paper already. There's another review article that is conditionally accepted in MedPhys. We still have to work on this a little bit. The software is made available upon request. We already have 2 external users and 2 more are interested parties in this. And I think we treated already 6 patients and maybe even more. I think about that now. With her software, we just treated our last patient last week, on December 6th. This is her software in action. This is the map screenshot. This is what this screenshot or this map looks inside my treatment planning system. We have tools even to show it in 3D into the treatment planning system. So in this tool, we see the map and we see in the CTV that the doctors drew in orange here, kind of in this 3D view. So it's a nice tool to kind of make sure that you're actually targeting everything that you want to target. And finally, this is how we deliver the treatment. This is a plan that Gabriela did using, I guess, 3 arcs, and this is 25. No, this patient was 20 gray in 1 fraction. You see the 50% isodose line. So you see the 10 gray lines all around with the heart here. As to kind of new research interests, well, I'm going to maybe look into improvements to this EDICO. EDICO is the name of the software that Sarah created. First of all, for usability, I would like maybe to make it a little bit more easy to give to other centers. So there might be just kind of improvements to the code to be made, and also connectability with other electroanatomical mapping systems. So now we use the one that we have here at the MUHC called Carto. But there's 3 or 4 different vendors that also have this export feature and kind of this of the data that we could try to import into its system also. So that would be a nice addition. Some of the people interested have these other systems, so that's why I'm saying that that's a nice project. I'm also looking into, and I guess I have slides on the other ones. I'm just going to go here. One thing that is also quite important for us is to find a way to contour all of these substructures in the heart. Right now, we have very little constraints on the substructures because nobody ever irradiated the heart, so we actually don't know what happens if you irradiate different substructures. But it would be nice to be able to automatically contour all of these substructures. So I have a project I'm going to try to start working on in order to have models that are able to also contour this. Now, some commercial softwares are able to do it with patients that don't have kind of pacemakers and metal artifacts and stuff like that. But as soon as you have metal artifacts, typically these software are just going to say, no, I'm not able to do it. I'm just going to stop after 3 or 4 slices because it's not normal to have metal within your right atrium, let's say. So that's kind of the difficulty of this project. Same thing goes for this 17-segment heart model, which is kind of the way that cardiologists talk in between each other as to different regions of the ventricle, right? So the ventricle is kind of separated into different regions. And if you look at it, it looks like a circle with 17 segments. So the cardiologist could talk to the radiation oncologist by saying, I would like you to radiate, segment 7, 13, and 17, let's say. And that means a certain specific region on the patient. So we'd like to have a way to actually generate these volumes also of the left ventricle within our treatment planning system to compare to what the doctors wanted. We're having also a lot of doctors from outside referring patients to us now. So that's also a nice way to communicate with them. Another project involves this newest gadget that cardiology has. It's called ECG imaging, and this particular device is called the Cardio Insight Vest. So by the way, cardiology is probably the second most gadgety department in the hospital after radiation oncology. So that's why they have all of these nice gadgets also. And with this vest, instead of having a contact mapping with these catheters that are, invasive, they have a way to now detect pretty much the same, the same data, like you see in this paper, just using this vest that is glued to the patient. And each of these vests basically detects the cardiac rhythm at different points. And then there's a 3D reconstruction of all of these rhythms into this map. Quite interesting. This is completely new also, so it would be nice to have access to this data inside of a treatment planning system as well. This is developed by Medtronic, by the way. Insight, so that's not a project. And one other here would be to talk about motion management during cardiac radioablation. So we recently got a new compression vest. So back in my master's, I was talking about we were using all of these compression devices. Over the years, we started not doing that anymore. We started just believing our beam CT, believing the initial immobilization and using larger margins to treat the patients. But I think there might be some benefits for these cardiac patients to look into the compression. There's some publications showing that helps a little bit. The extra difficulty also here is that you have a heart beating and a respiratory motion, so you have to kind of take that into account. Most of the time, they are of the same amplitude, let's say, so it's kind of accounting for one accounts for the other one. But this is a nice project to look at a little bit more in details by looking at actual data and whether it's useful. Yeah, I'm just going to skip this. And finally, a little bit related to this compression and respiratory is also to set up a protocol for cardiac MRI. So right now, these patients are really not prioritized for cardiac MRI. It's very difficult to have one from cardiology, but if they come to our department, we could use our MRI specifically for the patient that are going to have radiation therapy as a planning MRI in order to have a much better view of, especially of the myocardium, right, the thickness where we want to treat. So that could be quite interesting. And this would be a project that we would do with Dr. Yves Levesque as well. Here, requiring a little bit of work, probably in a research ethic board's approval first, and maybe even a clinical trial, or we could maybe tag along the clinical trial that we already have open for this. Okay, so this is a really project that is a multidisciplinary team of scientists and clinicians. I'm really not alone in this. I'm just a little pawn in the whole thing here. But we do have 2 clinical trials that are actually starting. So I've talked about one already. The second one, also super interesting, is not for VTs. It's for actually patients that are even worse and worse conditions than the ones that I was talking about, cardiac patients as well. It was shown that very low doses of radiation delivered to mice allow the heart to remodel itself also, right? So we're talking 6 grays. So we're going to open a clinical trial quite soon, trying to do that on patients. We might be the first in the world to try that. Those patients that basically have no other way and are basically dying within a few months of their cardiac disease might be eligible for that. Super exciting. We'll see how it goes. We have multiple grant proposals underway. Yeah, like I said, I already supervised Sarah, one student, have another. Julia starting soon in May. Extremely new field with a lot of research avenues still possible. Okay, so I'm still a clinical medical physicist 100% of the time. Quite the large interest in anything that's clinically implementable. Like I said, that's why I'm working on these projects. I very recently started supervising a few students. I don't have time for many students like Shirin has, but I'm not sure that Shirin has that much time also for all of you guys. Okay. But I have just a few students. But I'm always open to collaboration, especially if it's not me as a lead supervisor. If you need help or something, feel free to talk with me. Thank you very much.
Thanks. Thanks, Matt. Questions? Please in the room. Ask. You will tell online. Ask out loud or type it in the chat.
What, sorry if I missed this, but do you provide like a median age for the patients that would maybe get this kind of treatment?
What's the median age for
Yeah.
patients? Good question. I think it's still here. I would say like 60, but yeah, 60, and it's mainly males also. It's like 9 out of 10 is males, right? But
Yeah, can I ask a question? Better.
Right.
Yeah, thank you so much, Piotr. It's an amazing project and it's a great presentation at that. It's really interesting that you want to lower the dose to the heart, hopefully as much as possible, and still get the benefits with as low dose as possible, if I would say. Then I was wondering, you mentioned that the cellular mechanism of like why this works is not very well understood. People thought it's could be like fibrosis, but then it happens like patients recover almost immediately. If I were to guess, it's probably like the nervous system inside the heart that is being like impacted or fiddled with, rather than like the heart muscles or the connective tissue that would result into the fibroblasts. I was wondering if like people have done any work into like modeling the impact of radiation on the nervous system, and then on the nervous system of the heart specifically. It's going to be like another thing to go off. Is that like a reasonable direction to go down, or no?
Yeah, maybe, definitely it's a reasonable, but I'm not aware of any data in this field.
Yeah, sure. Thank you.
Do you think that this would ever be used as like a first intervention or standard of care down the line, or would it just be relegated?
Depends if you find doctors that want to do it. So yeah, the question was whether this could be a first intervention down the line for all patients. So in Italy, then let's say they have a clinical trial for not for VT, but for atrial fibrillation, which is another type of, say, irregular heartbeat. This is much less dangerous than VT. This is not deadly. This is still uncomfortable. And some patients with AF are not able to have any other treatments. And they're starting to do radiation therapy also to that. In the community, the cardiac community, it's not very well accepted, let's say, because people think they're too cowboyish about it, right? This is where like people are scared of radiation, right? That's why my first slide is that, hey, we know that we can use radiation on benign kind of disease also, not cancer. So yeah, difficult to say. I would say that if we were to open that to a larger population group, we would need to build 4 new bunkers probably. So that's something that we have to think about, right? Maybe not 4, but no, like I said, there's a lot of patients that could essentially benefit if we open that to everybody. But we're not there yet. It has to be slow.
Good. Any other questions? Do you think, I found it interesting you gave your grad projects. Do you think you'd be doing this now if you hadn't done those projects and the PhD?
Research?
Yeah.
No, I don't regret doing it, although my 4th year of my PhD, I was regretting it.
The grad school size.
Yeah, but now, no, I don't regret it. Definitely, that's the path that I choose, and I'm happy with it. Super.
Glad you're here today.
Yes.
All right, if there aren't any other questions, thank you, everyone. Thanks, Piotr, again. Thanks for that.